Yeah. Samir, you are muted again on like mobile. Yeah.
Okay, can you hear me now? I think
Yeah.
so. The topic of my presentation is pneumothorax, and the curriculum number RC8. I am one of the HIEM trainee. Today I'll be discussing on the introduction of the pneumothorax, the classification, causes, clinical and radiological assessment, and life-threatening tension pneumothorax, the management of it, and quite few words on discharge, referral, and advices. And at finally, I will have some question and answer sessions with you to know how we know about the topic. So coming towards the introduction, pneumothorax is basically a collection of the air in the pleural space. So pleural space is a potential space between the parietal pleura and the visceral pleura. The parietal pleura secretes around the 2.5 liter of the fluid per day, and which is absorbed by the visceral pleura. The basic pathology where the air enters into the pleural space is by two mechanisms, either through a communication through the chest wall to the external environment or by the rupture of the visceral pleura. So the pleura will extend around 2.5 centimeter above the mid-clavicular line upwards the 12th rib down, and the pleura is reflected around the hilum and onto the long chest wall and in the mediastinum. So depending upon the location, the pleura can be uh, called as the cervical pleura, the costal pleura, mediastinal pleura, and the diaphragmatic pleura. So when there is air accumulation inside the pleural space, then there will be some physiological changes, and there can be changes on the level of the pressure over there, which can cause a significant problem in the ventilation, oxygenation, and even both. And in higher clinical scenario, it can cause collapse of the lung, and we may lose life of the patient. And the presentation of pneumothorax can be variable. Sometimes it can be asymptomatic, and sometimes it can be very life-threatening. So prompt diagnosis and adequate clinical examination is very necessary from our setup. Regarding the classification, basically there are the two broad classification, namely called as the traumatic pneumothorax and atraumatic pneumothorax. However, the classification can be further subdivided according to the etiology, according to the physiology, and according to the size. Let's see what is the classification according to the etiology. It is traumatic pneumothorax. Basically, traumatic pneumothorax is caused by any blunt or penetrating chest trauma like gunshot injury or road traffic accident, fracture, etc. And iatrogenic pneumothorax, this is caused by any medical procedure and any interventions that we do to find out the pathology. And spontaneous pneumothorax, regarding spontaneous pneumothorax, there are two types. One is primary spontaneous pneumothorax, and second is the secondary spontaneous pneumothorax. Primary spontaneous pneumothorax occurs in people with no existing lung parenchymal disease and no any inciting events. And secondary pneumothorax occurs in people with a significant lung parenchymal or pleural diseases. And catamenial pneumothorax is the type of the pneumothorax that is common in the reproductive age women. It basically occurs in the right lung and typically occurs during menstruation or around the 72 hours after menstruation. And the basic pathology for catamenial pneumothorax is the endometriosis of the pleura. And regarding physiology, there are the three types of pneumothorax. One is simple pneumothorax, other is communicating pneumothorax, and next is the tension pneumothorax. In simple pneumothorax, there is no communication of the pleural space with the external environment, and there is no shift in the mediastinum. And in the communicating pneumothorax, there is a defect in the chest wall, and there is open communication between the chest wall, and which act as a medium for the air sucking inside the pleural space that results in the paradoxical lung collapse. And the next is our tension pneumothorax, and there is a progressive accumulation of the air inside the pleural space. There can be a there is a one valve switchation mechanism where air gets trapped but cannot get out. I will talk more about the tension pneumothorax in subsequent slides. And according to the size, pneumothorax are two types. One is small pneumothorax and one is large pneumothorax. Small pneumothorax, the size is less than 2 centimeter at the level of the hilum, and in the large pneumothorax, the visible rim is greater than 2 centimeter between the lung margin and the chest wall. And there are many etiologies and the risk factors for pneumothorax. The highlight of this slide is the logo no smoking, because spontaneous pneumothorax, primary spontaneous pneumothorax, they are more common in the smokers. And because smokers can leads to increased number of the inflammatory cells in the alveoli, and due to oxidative damage, people can easily get pneumothorax. Then another cause for primary spontaneous pneumothorax is thin build habitus, and in male people, the basic mechanism is that there is increased number of negative shear force at the apex of the lung, and there is increased distending pressure of the alveoli at the apex of the lung in such type of the individual, and which are the risk factor for developing of the subpleural belt. And in pregnancy, any alteration in the level of the air or any physiological changes can easily hamper the amount of the ventilation and oxygenation problem. And same thing regarding the Marfan syndrome and other connective tissue disorders. And some risk factors that are associated with the secondary spontaneous pneumothorax, and the disease they are associated with secondary spontaneous pneumothorax are most commonly the COPD patient and asthma patient, necrotizing pneumonia patient, and in patient with HIV infection, and particularly with the pneumocystis jirovecii infection, and other connective tissue disorder, cystic fibrosis, bronchogenic carcinomas, and in also in inhalation drug use like cocaine users. And the iatrogenic pneumothorax, like I mentioned earlier, most commonly during the central venous cannulation, subclavian vein cannulation, then any procedures regarding the lung, like pleural biopsy or lung biopsy, then even in the positive pressure ventilation or NIV situation, then it can lead to iatrogenic pneumothorax. Till now, we have discussed about the introduction, pathophysiology, and the risk factors. And the big headache is the ABCD assessment in our part, because patient may not have initially any symptoms and may land up in a very difficult situation. So it is our duty to thoroughly evaluate the patient and include differential diagnosis of the pneumothorax. Any patient who presents to the accident and emergency with shortness of breath or in the pleuritic chest pain. So in ABCD assessment of the spontaneous pneumothorax, they can be asymptomatic or even incidental finding, and because of the incidental finding, they can present very late to the emergency department because they do not have any symptoms. So and even the symptoms do not correlate closely with the size. The classic presentation, like I mentioned, is sudden onset of pleuritic chest pain and breathlessness. The pleuritic chest pain is a sudden onset. It is severe. It is stabbing type. It is like a tearing type, and often it radiates to the ipsilateral arm. So it easily mimics the acute coronary syndrome. And in some cases, people come with a very anxious and even they may have some mild cough. Often spontaneous pneumothorax, there will be the gradually resolution in 24 hours, and in the normal physical examination, because that can be an initial finding at most of the time. And 80 to 90% cases of the pneumothorax in the emergency department, they can be due to primary spontaneous pneumothorax. And secondary pneumothorax patient, they have more clinical severity, and they have more breathlessness because they have underlying lung parenchymal or other diseases, which has compromised their lung function. And the size of the pneumothorax is even the size of the pneumothorax is small. The patient can have great symptoms and hemodynamic compromise. If the pneumothorax is very large, then we can have the typical features like tachycardia, tachypnea. There can be the decreased breath sound on the lateral lung, and there can be the decreased chest expansion. And upon auscultation, we can hear hyperresonance, and there can be a decreased tactile and vocal parameters in the percussion. This is the table I have taken it from the RCM learning. It shows the differences between primary and secondary pneumothorax. The recurrence rate is variable between primary and secondary pneumothorax. The basic pathology is like a rupture of the subpleural breve. And in both pneumothorax, male patients are prone to get pneumothorax, and smokers, female, they have around 8-fold high risk to get pneumothorax than non-smokers. I have three X-rays in the screen. X-rays A, B, and C. These are the X-rays. They are taken from the emergency department. And in X-ray A, he's a 25 years old male with smoking history who presented to accident and emergency with abdominal pain. But in incidental finding, the X-ray shows abnormalities. I think you cannot see clearly. I will zoom it so that you can see it clearly. In the upper right zone of the lung, there is absence of the bronchovascular margin compared to the left side, like this and that, and there is clear visible rim of the pleura. So our diagnosis will be a pneumothorax, but we need to know whether it is spontaneous pneumothorax, primary or secondary or tension pneumothorax. So we take help of other things in the X-ray. We look upon the tracheal shift. The trachea is center. The mediastinum is normal. There is not so collapse of the lung. So and patient is stable. So this is a case of the primary spontaneous pneumothorax. Coming towards the second X-ray, she is a 62 years old female with a known case of COPD, present to emergency with shortness of breath and chest pain. And we thought it as a pneumothorax. We suspected as a diagnosis of pneumothorax, and we took chest X-ray. The chest X-ray revealed huge pneumothorax, large pneumothorax on the right, on the left side. There is not adequate mediastinal shift, and there is a visible, there is a increased number of bronchovascular margins, and the rib space are widened. So this can be a case of the emphysematous patient with a known case of the COPD. And so this is a case of the secondary spontaneous pneumothorax. And now our third case number C. We see in the X-ray that obvious. This is the obvious X-ray. Everyone will be frightened after seeing this X-ray, because most of the time the diagnosis is clinical, and when we see this type of the X-ray, we are hurried. We clearly see that there is a massive pneumothorax with the mediastinal shift and collapse of the ipsilateral lung and compression of the contralateral lung. So this is the typical X-ray of the tension pneumothorax. We can see some tubing over here, and also some pathologies are seen in the bones and the lung parenchyma as well. So moving towards the next slide, after the clear chief complaint and ABCD assessment, our further procedure is like obtaining the detailed history of the patient. But when the clinical severity is high, then we proceed to treatment immediately rather than taking the history. But regarding the history, we should ask about age, the duration of breathlessness, and any history of associated trauma, penetrating or blunt trauma, any past medical history, any medication has been taken, and any previous chest X-rays, and any history of the previous pneumothorax. If the patient had a history of previous pneumothorax, then we should ask about the side of the pneumothorax, the size of the pneumothorax, if possible. We need to see the patient record at the hospital, and what was the treatment strategy he had been given. And regarding the occupational and social history, like smoking, family history, sometimes there can be a familial pneumothorax as well. occupations like frequently flying patient and those who enjoy scuba diving, they are at high risk of the pneumothorax. And currently menstruating women, this can be also we should include in our history. And the differential diagnosis, coming towards the differential diagnosis, anything that causes breathlessness and chest pain, we should include as a differential diagnosis. That can include the like pneumonia, acute exacerbation of the asthma, then the carcinomas, diaphragmatic injury, rib fractures, acute coronary syndromes, pulmonary embolism. Everything comes as a differential diagnosis, even pericarditis, myocarditis. And the basic investigation we do in the emergency, after doing the complete blood count, putting the patient to the oxygens, then evaluating the vitals, to examination, then we proceed towards the radiological investigation. The first choice, our first choice is chest X-ray. X-ray can, most of the time, X-ray can show the pneumothorax if it is a large one. But sometimes there can be features whereas chest X-ray does not show any pneumothorax, but we are suspicious about the pneumothorax and we have ordered CT scan, but CT scan will reveal the pneumothorax. And chest X-ray, basically inspiratory film is recommended, and chest X-ray being a two-dimension things, then the adequate size of the pneumothorax is very difficult to define. Then sometimes and supine and even lateral decubitus X-ray is required in trauma patient. In the trauma patient, direct X-ray is if impossible, then we will do the supine X-ray, and in supine X-ray that can be the sign like double diaphragmatic sign or deep sulcus sign in supine X-ray, which we will notice as a case of the pneumothorax. The CT scan is the gold standard investigation because it can quantify the amount of pneumothorax, as well as we can know more about the underlying pathology from the CT scan. Also, we can know about the occult pneumothorax if the patient is, if we regard the patient as the suspicious of the pneumothorax. Then in the recent scenario, long ultrasound has become the very useful measures for doctors in the emergency department. Long ultrasound is very important, and we should have training of the to identify and rule out the pneumothorax. And it is very easy to identify pneumothorax in long ultrasound. In long ultrasound, we will look about the lung sliding. If there is absence of the lung sliding, and we will also look about the lung point, and there can be the reverberation artifact like airlines, which can present in the pneumothorax patient. And in recent advances like digital imaging, which will provide opportunity for us to magnify the image, to manipulate the contrast manipulation of the image, to save the image, and it can be very helpful in our scenarios. And the management at emergency department is basically depends upon the severity of the cases. But basic management is in our setup is to eliminate the air that is present in the pleural cavity, to encourage the re-expansion of the pleural space, to encourage the healing of the fistulas or the pathologies, and to prevent the recurrence. The management depend upon severity. Like if the patient is asymptomatic or if it is the incidental finding, then we will discharge the patient and ask him to follow up in a few weeks. But if their patient is asymptomatic, and patient is asymptomatic, and but he is stable, then we can also put him in the high flow oxygen cannula and put it under observation for a few hours in the emergency department, and we'll consult with our seniors. And small primary spontaneous pneumothorax, without any significant breathlessness, just observation, or you can discharge it. And whatever the size of the pneumothorax, if the patient is breathlessness, then active intervention should be done. And immediately we should proceed to the chest drain in case of the bilateral pneumothorax. If the of the pneumothorax is due to the tension pneumothorax, or it is due to the trauma. This is the flow chart I have taken is from the British Thoracic Guidelines Society 2010. And this is the flow chart showing the management of the spontaneous pneumothorax. In the left hand side, you can show the primary pneumothorax management. In the right hand side, is the secondary spontaneous pneumothorax management. The BTS has regarded age greater than 50 years with significant smoking history and in the presence of the underlying lung disease as a secondary pneumothorax, and the management depends upon the size and the amount of the breathlessness over there. Mm. The basic highlight of this slide is if the patient has a primary spontaneous pneumothorax and the size is greater than 2 centimeter, or if the patient is breathlessness, then we proceed towards the nasal aspiration. But the case of the secondary pneumothorax, if the size is greater than 2 centimeter or breathlessness, we proceed directly towards the chest drain insertion. The chest drain insertion, I will talk more on subsequent slides. I think you can go through this slide. This is also this slide is this flowchart is also given in our fifth edition of the emergency medicine handbook. And regarding the pharmacotherapy, our job is not done yet. We identified the pneumothorax. Then our duty is to ensure that patient does not have any pain. So pain management is necessary. Before inserting the chest drain, we can give local infiltration of the local anesthesia. Then we can also give a procedural sedation, any oral or IV NSAIDs, and even intercostal nerve block. And the another pharmacotherapy for pneumothorax is pleurodesis. Pleurodesis is generally given for the recurrent pneumothorax, and this is not done in emergency setup. Patient will be admitted to the ICUs, and the respiratory specialist will do a pleurodesis. I will have some words on chemical and medical pleurodesis. Pleurodesis is simply means that installing through the chest drain we will install some drugs. Basically, we will use the sclerosing agent like tetracycline 500 milligram or grade 8 talc powder. Then it will cause is the aseptic inflammation with dense adhesion. That cause there will be no potential space between the parietal pleura and the visceral pleura, and so the pneumothorax will not occur in the subsequent time. And there can be also a surgical management for pneumothorax. This is not done in our emergency department. People will go for open thoracotomy or a video assisted thoracoscopic surgery. That is the surgery of choice nowadays, because it is the hospital admission days is very less, and patient will have less symptoms and better tolerated than open thoracotomy. But the recurrence rate is high, like 5% compared to the open thoracotomy. Now, some words regarding the pneumothorax. The picture on the right hand side, we can observe that the heart and the lungs is compressed by the air. So this is the medical emergencies, because patient may land up in respiratory failure, even cardiac arrest. Patient can land up in a shock or even arrhythmias, and may even lose their life if we do not found this condition early. And it can be life-saving as well if early intervention is done. This is a radiological diagnosis. We should not wait for X-rays if we are suspicious of pneumothorax. It is better that we do a needle aspiration rather than rushing towards the X-ray, because needle aspiration at one time will not harm the patient more than the delaying for the treatment. There can be it is a like the pathophysiology is it act as a one valve situation where there is a subsequent air trapping. Due to air trapping, there is can be the increase in the pleural pressure inside the lung, and which will make the ipsilateral lung collapse and cause the contralateral lung to compression. Also, it will compress the great vessels like vena cava, superior vena cavas, and angulation of the inferior vena cava, which causes the decreased venous return to the heart. and due to decreased venous return, there is decreased diastolic feeling, and heart cannot pump the blood adequately. So people will have a hypotension, and even it can be catastrophic situation. Sign and symptoms like chest pain, shortness of breath, profound hypoxia, and hypotension can be present, and people often have respiratory failure in the ABG, and it can be a cardiac arrest situation. But surprisingly, less than 25% patient have tracheal deviation, hypotension, neck vein distension, and hyperresonance. So that we should not rely more upon the typical signs of the pneumothorax. This is the um, this is the sign and symptoms. This is the mnemonics showing the sign of symptoms. P thorax, like P for pleuritic pain, T for tracheal deviation, S for hyperresonance, O for onset sudden, R for reduced breath sound and dyspnea, A for absent phragmitus, and X for X-rays shows collapse of the ipsilateral lung. Causes of tension pneumothorax are any like blunt and penetrating trauma. However, like bariatric trauma in the mechanical, if the patient is mechanically ventilated and in positive pressure ventilation, or even in NIV, and in some cases like percutaneous tracheostomy, and cases like the conversion of spontaneous pneumothorax to tension pneumothorax, and even in during the resuscitation like a CPR, there can be fracture rib, and which can cause pneumothorax as well. And in patients who have already into the chest drain due to blockage or clamping of the tube, then there can be a tension pneumothorax situation. Regarding the management, immediate management is needle aspiration, which is followed by the immediate insertion of the chest drain. And the history part we will take later, because the patient, we may not have sufficient time to take the history, because this is a very important and very emergency situation, and it is very life saving as well. And the procedure is not so difficult in emergency department, and every emergency physician resident and even nursing staff should have clear idea how to do a needle aspiration and when to call a senior doctor. Needle aspiration is done in the second intercostal space in the mid clavicular line, like I have shown in the picture in the right side. And the needle's size is usually done by 14 to 16 gauge needle. Sometimes in the obese patient, it may not be sufficient depth. So people often use angiocatheter, 5 centimeter angiocatheter as a needle aspiration. And needle aspiration is very effective, like insertion of the large bore greater than 20 French chest drain. And the BTS guidelines has recommended immediate insertion of the chest drain after needle aspiration. And needle aspiration, if once failed, should not be repeated twice. And needle, if there is no hissing of the ear in the needle aspiration, then we cannot rule out tension pneumothorax. The second treatment is insertion of the intercostal chest drain. Adequate learning, adequate practice, and experience is very important to insert a chest drain. And we may be panic at the time, being a junior doctor, but if we practice more and if we observe more, then it will be we can. I think we can do it. The chest drain is basically a tube which is placed inside the pleural space to drain fluid, blood, or air. We can also instill antibiotics like antibiotics, sclerosing agent, or even saline if the tube is blocked. The tube is intercostal chest drain tube is inserted in the triangle of the safety, like shown in the picture. In the right triangle of safety, this margin is the lateral margin of the pectoralis major muscle, and the lateral margin of the latissimus dorsi muscle, and inferiorly it is the 4th to 5th ribs. And the site is anterior to the mid axillary line. And the indications, some indications for chest drain insertion in pneumothorax, like in any ventilated patient, like in patient is in the mechanical ventilation and there is sudden deterioration of the patient clinical condition and the airway pressure has increased, then we will suspect the case of the tension pneumothorax. and there is a persistent or a recurrent pneumothorax after simple aspiration. If there is failure of our needle aspiration, then we proceed directly to the intercostal chest drain. Then if the secondary spontaneous pneumothorax is very large, then we also uh, put chest drain as the primary treatment. There are some contraindications regarding the chest tube, but in the emergency, we look very few into this. The absolute contraindication is lack of informed written consent or patient cooperation, because in the time of accident, and if there is no one to no one with the patient, then we will proceed whatever is beneficial for the patient. But if the patient is in the state of giving the consent, then we can obviously we will take a consent from the patient or the patient party. Then there is relative contraindications like uncorrected coagulopathy and platelets count less than 50,000. I have discussed about this in earlier slides. These are the recommendations from the British Thoracic Guidelines 2010, like small bore less than or equal to 15 French is recommended for a tension pneumothorax. We should not rush to put the large bore chest drain to the tension pneumothorax. Large bore chest drain is only indicated in case of if pneumothorax is associated with pneumothorax, and if the small pneumothorax has small chest drain has failed. Then in case of the pleural effusion also, and in case of empyema also, small bore new chest drain is recommended. Adequate pain relief should be our priority, and when there is a trauma situation, cefazolin 2 grams can be given to the patient. It is done in aseptic condition using ultrasound guidance. RCAM has recommended that ultrasound is very necessary, and never inserted with a substantial force. It should be inserted very lightly, and use of the trocar is absolute these days, because of the risks of the damage to the parenchyma of the lung. And there are the basically two techniques, like a Schillinger technique for small bore chest drain, and blunt dissection technique for large bore chest drain. Schillinger technique is similar to insertion of central venous catheterization, like we have practiced. These are the some complications of pneumothorax and chest drain. I have mentioned, like a passenger may land up into hypoxic respiratory failure, cardiac arrest, then empyema, and the chest tube related pathology like re-expansion pulmonary edema. It is caused by the histological changes in the lungs, by the reperfusion, the um, free radicals will increase in the lungs, and that can cause increased permeability of the lungs, so that the people immediately after insertion of the chest and people may experience chest heaviness, tachycardia, and cough. If patient experience that, then we can suspect of the re-expansion pulmonary edema. Then we should clamp the tube. And some iatrogenic complications of insertion, like tube blockage, malposition. Sometimes the tube can go subcutaneously, or sometimes it will end up in the interfissural space. Sometimes it can go too deep into the parenchymal. So chest X-ray after insertion of the chest tube is very necessary, and adequate instructions should be given to the nurse regarding the management of the chest tube, and if any clinical deterioration happens. So now we have discussed regarding the management at emergency department, but every patient should not be admitted and may not be admitted. So disposition and admission and referral are very critical part in our setup. Our job is not done yet after insertion of the chest tube. We should look after the complication, immediate complication after insertion of the chest tube, and further complications. So patient with secondary spontaneous pneumothorax need admission for ICU, because that can convert into tension pneumothorax. So ICU admission is very necessary. And once patient is admitted inside the hospital, then he should be consulted with the respiratory physician within 24 hours. And at sometimes patient should be referred to the cardiothoracic surgeon for their best opinion. These are the some scenarios where we should consult cardiothoracic surgeon, like the case of second ipsilateral pneumothorax, first case of contralateral pneumothorax, if there is a synchronous bilateral spontaneous pneumothorax, and if there is persistent ear leak or failure of the chest re-expansion after insertion of the chest tube, if there is spontaneous pneumothorax, and people who are at professions like pilots or divers, then we should immediately do cardiothoracic surgeon consultation, because they may need a different management rather than chest tube insertion, like surgical procedures. And in pregnant patient, he or she should be referred to the CTBS surgeon immediately. And regarding discharge and advices, if the patient is asymptomatic and a incidental finding and the size of pneumothorax is less than 2 centimeter, we can discharge the patient. And if asymptomatic, size is less than 2 centimeter, and even after size is 2 centimeter after needle aspiration, it was greater than 2 centimeter before, but we do a needle aspiration and the size is now less than 2 centimeter, patient symptoms has been improved, then we can consider him for discharge. But before discharge, it is the rule to give the both verbal and written consent to the patient, and to the patient regarding when to return to the return to the emergency immediately if he or she encountered breathlessness. And advice regarding smoking cessation is very important in our setting. And the advice regarding flying, it is very important. I have taken this from the RCAM site. Flight should be flight should be avoided for at least a week. Initially it was 2 weeks, but now it has been written as a week after confirmed complete resolution of spontaneous pneumothorax on chest X-ray or recovery from a surgical procedure. However, in case of the traumatic origin, 2 weeks of complete resolution should be adequate for discharge. And flying, regarding diving, underwater diving should be permanently avoided after pneumothorax unless patient has had bilateral open surgical pleurectomy. Then the follow-up, if the patient is ready for discharge, then follow-up with the respiratory physician should be done in 1 or 2 weeks. And if it is difficult to get a date with the respiratory physicians or a GP, then follow-up at the emergency department with the previous X-ray can be done. And finally, these are my take-home messages. The highlight is encourage to avoid smoking, and pneumothorax, it can be basically traumatic and atraumatic. It can be symptomatic to life-threatening, and sudden onset of pleurotic chest pain and shortness of breath. Spontaneous pneumothorax should be always on the differential diagnosis. Misdiagnosis is a frequent complications in emergency department. We may not think that it may be a pneumothorax. We think of more about the cardiac causes. And high flow oxygen administration will resolve this pneumothorax 4 times faster. This mechanism is similar to like the pre-oxygenation in during the intubation. And a needle aspiration at a second intercostal space at a mid-clavicular line, and a chest drain at triangle of safety. The absence of his unattempted needle aspiration does not rule out tension pneumothorax. Small bore chest drain is recommended. And management of pneumothorax, it is done by the multidisciplinary team, and interpersonal team approach is very important. The emergency physician, senior emergency physician, the cardiothoracic surgeons, respiratory therapist, and nursing staffs. Their coordination is very important for overall management of the pneumothorax patient. Now we will have some discussion and question answers sessions regarding the pneumothorax. I have some MCQs regarding the pneumothorax. I will read out the questions, and I will look forward to get answers from you. The question number 1 is which of the following is associated with an increased risk of developing a primary spontaneous pneumothorax?
Samir, your like PDF is not visible. You have to like stop sharing and you can start sharing for PDF.
Okay, thank you.
Okay, Samir. Yeah, so it's a very good presentation, Samir. Really nice.
He hasn't finished, Mr. Ginger.
Oh, you're not
Sir, I
finished
have
because
some
because
questions.
I
We
no,
can
I want to leave to attend another meeting. That's why I'm praising him. So yeah, so I may be allowed to leave. Okay, guys.
Okay, sir, I will
No,
take
no,
my
Sundar, I was listening. I know your cheeky smile. I was listening throughout his presentation. Okay, so may I allowed to leave?
Yeah, Mr. Ginger. So
Okay, thanks you guys.
Thank you,
Thanks,
Mr.
Samir.
Ginger. Yeah.
Okay, take care. Bye.
Bye.
So here is the question 1. Which of the following is associated with an increased risk of developing a primary spontaneous pneumothorax? And the answer is
D.
yeah.
Okay.
Yes, answer is D.
Smoking.
And question number 2. Which of the following statement regarding secondary spontaneous pneumothorax is true? The usual cause is rupture of subpleural bleph. Marfan syndrome is a recognized cause. Chest drain insertion is always required. Chest wall trauma is a recognized cause.
A.
And
E.
it's a it's a E. 1 to 5% of the patient that increased risks of pneumothorax. And question number 3. Which of the following signs and symptoms is of most used in determining the best treatment option for small spontaneous pneumothorax? Options are pneumatic chest pain, nicotine stent fingers, no abnormality found in clinical examination, high arch palate, and breathlessness. The answer is E. And question number 4. Which of the following is the most sensitive for detecting a spontaneous pneumothorax? The options are here. And the answer is
CT.
yeah,
A.
it's a CT scan. And question number 5. Which of the following factors will influence the decision whether to perform needle aspiration or insert a chest drain in a secondary spontaneous pneumothorax in a stable patient?
D.
Yeah,
G side of the
answer is D.
pneumothorax.
Yeah. And question number 6. A young asthmatic male patient complaining of severe pleuritic pain. His observations are normal and a chest radiograph demonstrate a 3 centimeter pneumothorax. Which of the following treatment is absolutely contraindicated?
Antonox.
Yeah, it's Antinox. It's a commonly asked question in primary examination. And question number 7. Of 45 years old patient with COPD presents with 2.5 centimeter of spontaneous pneumothorax. Choose the most appropriate emergency department treatment from the following list. What may be the answer?
A. 7A.
No, the answer is fixed concentration oxygen and insertion of small chest drain. The size is 2.5 centimeter. And it is the case of the secondary pneumothorax. So the
Yeah,
size
chest
2.5 centimeters.
Yeah.
So we proceed directly to the chest drain. Regarding spontaneous tension pneumothorax, choose the best answer from the following list. It should never be diagnosed radiologically. If cardiac arrest ensues, then it is usually secondary to the respiratory arrest. Absence of his unattempted needle decompression visually excludes the diagnosis. Tracheal deviation and neck vein distension are expected findings, and hypoxia is uncommon. The answer is
A.
B. So it's the best answer. If cardiac arrest ensues, then it is usually secondary to respiratory arrest. This is the case of tension pneumothorax. This is also correct, but this is the best option here. Sometimes CT is very necessary to know about tension pneumothorax because 25% cases the clinical signs and symptoms are not apparent. With regard to spontaneous pneumothorax, which of the following is an indication for cardiothoracic referral?
Number C.
Yeah, C.
A.
This is for respiratory physician and duration is 24 hours.
Okay.
Recurrence of
Answer
ipsilateral.
is E.
E then.
Recurrence of ipsilateral. And last one, you perform needle decompression with a 14 gauge cannula in the second intercostal space, but here no hiss. The patient's condition continues to deteriorate. At this stage, you should perform an open thoracostomy, attempt needle decompression, insert a small chest drain, insert a large chest drain, and perform an open thoracotomy.
It would be A, I think.
Yeah, it's the
Open thoracotomy.
yeah. Thank you very much for your cooperation.
Okay, thank you, Samir, for like this pneumothorax presentation. So if you have any questions or any suggestion, we can discuss now.
Presentation, great presentation, Samir. So I just want to highlight one thing that you mentioned earlier. There's always a debate about the insertion of the needle thoracostomy in which space. Now with the HLS 10 edition guideline, basically says it's supposed to be the space has changed now. It's from the second intercostal space, it has moved on to the fifth intercostal space at the mid-axillary line. It's not to disappoint any one of you, but basically, if you look at it, if in a thinner chest wall, it's likely possible to put in more easily in the fifth intercostal space because it has got a thinner chest wall. If it's a thick chest wall, you never attempt to do in the second intercostal. Reason being, I'll just show you a slide which explains that. So I'm just going to share the screen. Yeah. Okay. If you look at this, this is the device actually placed in the second intercostal space. But can you see the tip? It just reached over there. It has actually not gone inside. Okay. That is the main reason. As you can see, the skin thickness right here is quite thick. In increased body habitus, and basically who has got a thick chest wall and quite a person, try and go around this side. It's not clearly visible here because it's not the right section. It's around the axilla area we're looking at. But if you go down, it gets more thinner at the fifth intercostal space. So try and do in the fifth intercostal space in the mid-axillary line. That is the guidelines for from the ATLS guidelines from the 10th edition onwards. That is the change that has been mentioned. If you want to read up to, then you can go to Life in the Fast Lane in tension pneumothorax, time to change the old mantra. Okay, so this is a kind of good read. You can go ahead with that. And basically, the only two disadvantages with this one is a less easy access, which is understandable. It is easy to just puncture the second intercostal space and just to get done with it. But another thing is like if the patient is being transferred from either, like laying on one position or getting the chest x-ray in a long term, then whenever you put the catheter in the fifth intercostal space, it might get dislodged. That is the only questionable doubt that we have whether to continue with that or not. But clearly speaking, your reflex activity goes to second intercostal space, his sound, done job. No, the hiss sound may not be appreciable sometimes. But if you do put a needle in, make sure it rather be a cannula, and around the cannula, you get any like a tape from the emergency department, you keep it around first. So that, and then on top of that tape, which is circumscribing the cannula, and then put the tape all around. So what you do is you keep that cannula in place for a longer time before the chest thoracostomy tube is actually being placed. That is the main highlight I want to share about, but excellent presentation.
Thank you for sharing this with us.
Samir, you have done very good job. I think. So as Suraj said, in the ATLS guideline 10 edition, they said only one site, that is 15th intercostal space. There is no other site. So there is no confusion between putting in the second intercostal pressure or 15th intercostal space. From now, if you got any pneumothorax, and just put in the 15th intercostal space. There is no other side. Am I right, Suraj?
That's correct.
Suraj?
Yeah, that's correct. The only thing is
The only thing is, Sikandar, in pediatric population, it is still second intercostal space. This is for adult trauma.
Yeah, in the pediatric, there is still second intercostal. Hopefully, they will change it soon as well, because they have given so many. I've gone through the 10th edition, and they have given the very clear cut indications of giving the in the 5th intercostal space. So I think I have not gone through the pediatric, but yeah, there is still I can see that one. Yes, thank you.
One of the advantages for the 5th intercostal space that has been mentioned is there are no major blood vessels in there. Whereas if you go into second intercostal space, there's a likely chance of you damaging the internal mammary vessels. That is one of the reasons they've mentioned, but doesn't mean that it has actually gone up. But the thing is, once the guideline changes, you need to change the practice. That is the only thing that you need to
I think
kind of highlight on. But overall, absolutely fine.
Sorry. In addition to that, I think they noted that a lot of the needles which was going into the second intercostal space were too medial, and it wasn't really doing the job. So that's why they kind of moved to the 5th intercostal space, just anterior to the mid-axillary line. So I think it's just a way of making sure that the pressure is relieved, because a lot of people put the needle too medial and the patient is going into a tension pneumothorax. But it was a nice presentation, Simon. Thank you.
Samir, one more thing I would like to highlight. You prepared the slide; those are slides, the best slides. So one thing I will say, if you're preparing for any slides for the educational purpose or presentation for education purpose, then your background should be white. This is what RCM guidelines said. Just now you have done very good job. Still, there is your background is black. So I think professor already mentioned us, you have to prepare your slide with the white background. So if you're preparing for the next time, then make sure that you're preparing the white background.
Sure, I'll do that.
Good. So Sundar, I think we already passed 12 minutes. So
just to highlight one more thing, guys. It has been more easy access to POCUS in any research case like this. So try and hold your ultrasound probe as much as you can to have an idea, what does it look like? What's the normal looking like? And what does the sliding of the pleura that is seen in the normal individual versus what is seen in the pneumothorax patients. So there's a lot of a kind of sliding of the pleura would be seen in normal patients, but however in patients with pneumothorax, that sliding is absent. you can see some kind of pleural, kind of like a curving of the pleura. So basically it's not causing it to slide properly. And you might actually see some internal B lines sometimes if there is any underlying kind of consolidation or something. But having said that, and also you can see in M mode, if you go, you find a seesaw sign. Basically, in the seesaw, you can actually see like a proper contrast between the C and the sore. Same way in ultrasound, you can actually see that separation very clearly. But in the one which has got pneumothorax, you may not actually see that kind of separation. So you may have to look into like the POCUSatlas.com or some other website which explains more better in the trauma cases, because nowadays fast scan, e-fast, involves a lung scan which involves this pneumothorax detection.
Okay, then we will end the today's session. Thank you, everyone.